Hello, everyone. This is Jaisy Vargas. I am recording this patho prep for renal disorders. For those who students have trouble understanding the pathophysiology, the laboratory results, and the test questions on urinary tract disorders or kidney functions. So this particular slide is only focusing on the renal disorders. I want you to pay attention to the basic anatomy and physiology before you proceed to these slides. Basically, these disorders consist of organs, kidneys, ureters, and urethra. And make sure you know that the renal system filters approximately 200 liters of fluids per day from the renal blood flow, and it also allows metabolic waste products, toxins, and to be excreted from our body. At the same time, keep the essential particles in the blood. So this is important for you to know the basic physiological process. Make sure that you relate these kidney disorders with the blood pressure, fluid volume, and because the kidneys control, regulates the volume of the fluids, vitamin D conversion, pH balance, metabolic waste, and excretion of drugs, and it also synthesizes hormones. Now I want you to go back to the cardiovascular system disorders and connect that with fluid electrolyte imbalances and blood pressure regulations, how kidney is one of the major organs that support that function. And know your anatomy of the kidneys, all parts of kidneys and nephrons, the arteries and veins that supplies them. There are plenty of pictures that are available in the books that you have, or also online, and study those, like know the terms, get comfortable with the tubules, efferent and afferent arterioles, Bowman's capsule, cortex and medulla, because some of the questions will be using these terms to derive the questions so you can answer them correctly. And keep in mind the metabolic waste that is excreted from the body are ammonia, uric acid, urochrome. They are in the kidneys, and also urea and water from kidneys and skin. CO2 and water is from lungs, bile, of course, from the liver and small intestine. So I put this slide just to give you a freshening up on the kidney regulations and how it controls the fluid volume and how it connects to the cardiovascular regulations also. Make sure you review the diagnostic tests for renal disorders. So these are some of the examples that we commonly use in the clinical settings. eGFR comes a lot of times on these exams questions, BUN and creatinine. Then these are the testing that we use in the clinical setting, the CKD-EPI ratio, how to estimate the eGFR, and the CKD-EPI creatinine with cystatin C. So these are also specific tests we use before we administer certain drugs, especially in the hematology oncology clinics. Here's like 3 of them that you will see on the boards. Renal ultrasound, abdominal CT is used to rule out nephrolithiasis. Kidney stones are much better viewed in a CT than a renal ultrasound. Of course, it rules out any obstruction of the ureter. It also gives you if the bladder is as extra collection of water or urine, and also in emergency room, they will do an abdominal CT to rule out kidney stones. Intravenous pyelogram is also read through those diagnostic tests for these. Let's start with your elimination disorders, which is very commonly seen in the clinical setting, incontinence. There are 3 types. You will see these on questions: overflow, stress, and urge. And I have described each of them with the clinical examples. So study this entire slide. Intrinsic sphincter deficiency is seen on questions. Patients with the BPH after their prostate is removed, it's also seen. Urge incontinence, a lot of students get confused with all of those. So think about these diagnoses so you can relate that with these types. And here are 4 sentences. I want you to know this because this is very commonly seen in the progress report, or when there is a coding, you have to do, when you bill and code, you have to put a diagnosis on these symptoms. So mixed incontinence is when you have more than stress, urge, or overflow, more than one of the above, you call that mixed. And functional is usually when you have anxiety, depression, or PTSD, they have a functional incontinence. And when there is uncontrollable urination, you call that gross total incontinence. Transient incontinence is seen often on the board exam, so I have elaborated that here. The mnemonic is diapers. So delirium, infection, atrophy, pharmaceuticals, which is drugs, and excessive urine output, restricted mobility, and stool impaction. So the diapers will give you those, allow you to remember those if there is a question related to transient incontinence. In this slide, I have a little pathophysiological sentences on neurogenic bladder, which is also an elimination disorder. There are two types, spastic and flaccid. This comes on boards all the time, especially with the spinal cord injury patients and alcohol. So memorize this slide and know where the lesions are above and below caused by the detrusor hyperreflexia. And if it's below S1, it is detrusor areflexia. Sample cauda echinus syndrome. This is often seen on these boards. Renal obstruction, renal calculi is very much seen on almost all the exams, Patho, Pharm, and cardiac, and state board exams. So study this slide. RAS is, although I explained it on the next slide, again, I'm bringing it up because we have reviewed this in the cardiovascular videos. So how does it connect to high blood pressure, unilateral kidney obstruction, and hypertension? This is very important. I've seen this in many times with years of teaching students. So this is very important for nurses to know how it's connected to kidney stones and hypertension. Lower urinary tract obstruction is common in male than females. And keep in mind, if you have a kidney stone related question, know that the most common type is calcium oxalate. Make sure you ask the patients if they're on any supplements. Tums has 500 milligrams of calcium. So if they use that over the counter, that is a high risk for calcium stones. And when there is a referred pain related question, look for answer choices like umbilical area. That means the kidney stones are past. Okay, that's this one. And I have described 4 different types of renal stones in here. So this is the description of those. What makes a patient high risk for developing calcium oxalate stones. As we know, hypercalcemia is one of the causes. Hypercalcemia is seen in primary hyperparathyroidism, patients who takes high levels of calcium, any diseases that affects the kidney tubules, Cushing's disease, and high levels of aldosterone. Hypercalciuria is the risk factor. And what has intestinal malabsorption do with it, right? Patients with IBS and pancreatitis, they have hyperoxaluria, and that causes calcium oxalate crystals in the urine. Struvite and calcium carbonate, this comes on board exams for APRNs a lot. So bringing this up for you to study this, okay? Klebsiella pneumonia and Proteus mirabilis are the 2 common bacteria. They come all the time because these 2 bacteria increases ammonia production from urease. So these bacteria is known to produce urease, so they increases ammonia production in women. UTI is common cause in children, and they produce large size struvite stones if it happens in children. Uric acid, know that uric acid is related to uric acid concentration in the urine, especially in patients with gout and also myelodysplastic syndrome or myeloproliferative syndrome. Cystine and xanthine stones are very rarely seen, but you will see these under genetic disorders with abnormal excretion of cystine. So study this slide. And here's the RAS and hypertension connection. I brought this up again from cardiovascular disorders. You have to know the pathophysiology. When RAS is activated inappropriately, kidneys will undergo hypoperfusion. That means low blood volume and low blood pressure. Hypoperfusion means hypotension. This releases renin, which is the enzyme that converts angiotensinogen to angiotensin 1. Remember, we give ACE inhibitors to patients who have high blood pressure and they have kidney. We are protecting the kidney by giving this. Angiotensin 1 is converted by angiotensin converting enzyme, which is also called as ACE inhibitor. So to angiotensin 2, which is a potent vasoconstrictor, it stimulates the adrenal gland to produce aldosterone. and that raises the blood pressure. So we want to inhibit that mechanism by giving ACE inhibitors. Aldosterone, why inhibiting that process? Because what does aldosterone do? It attracts sodium and increases the water and blood volume. Body is trying to increase high blood pressure as it's trying to compensate. So this is the pathological process in hypertension. Study this slide. AKI, renal injury, always know this, okay? This comes on the clinical setting, emergency room, and also on boards. Post and pre-renal is very common. Post-renal is, think when your kidney prevents drainage of urine, meaning there is some kind of obstruction. It can be a tumor, can be a clot like a thrombus or a stone. Pre-renal is where there is a drop in GFR, glomerular filtration rate. Pre-renal is the most common cause of AKI. Hypoperfusion of kidneys, meaning decreased volume of blood, usually happens patients with blood loss after a motor vehicle accident, and also decreased cardiac output in patients with heart failure. Pre-renal is seen in blood loss, heart failure, vomiting, diarrhea, and fluid sequestration in burns patient. It is also seen as an intrinsic reason where acute glomerulonephritis is the cause. So most common cause, understand that if it's an intrinsic factor that is affected with the kidney disease underlying causing effect on renal tubules and glomeruli, then acute glomerulonephritis will be the reason. And then vascular reasons for AKI is arterial and venous obstruction of the renal system, malignant hypertension. Some medications that we often seen is NSAID, PPIs, mesalamines, and aminoglycosides, lithium, amphotericin Bs. These are very, make sure you're comfortable knowing these and study this by heart because these will be seen on these questions. Continuing on that kidney injury slide, cardiovascular failure and hypovolemia are considered pre-renal causes. Vascular diseases, glomerulonephritis are intrarenal causes, and extrarenal and intrarenal obstruction and bladder rupture are post-renal causes of AKI. And genetic causes are autosomal dominant polycystic kidney disease. Sometimes erythropoietic mechanism can cause a CKD and anemia. Benign tumors like MEN type 1, endocrine neoplasia is one of them that can also affect. So keep in mind, benign tumors, renal tumors are usually benign and they are not malignant. And an example is the MEN1 type. Okay, so I had one student had this question years ago. So I'm bringing that up this time so you will know that it is not malignant all the time, renal tumors. You cannot usually see that in the renal ultrasound, like a adenoma, they say, and then we do a abdominal CT to rule out if it's actual tumors. Usually sits right on the cortex. Glomerular conditions. Acute glomerulonephritis is often seen on these exams. So think RBC. RBC cast is seen. That's a hallmark of glomerulonephritis. Okay, RBC, not WBC. When you see WBC cast, you want to think pyelonephritis, urinary tract infection. Glomerulonephritis, you will see a lot of inflammation within the glomeruli, which causes hematuria, proteinuria, and hypertension. Those are the three signs, the three conditions that you have to remember, okay? Hematuria, proteinuria, and hypertension related to glomerular conditions. And normal GFR is 60 and above. You will see a reduction in this GFR. Remember in the beginning, we say how to calculate eGFR. So this is situation that nurse practitioners will calculate those because to give certain medications, you want to know the eGFR, otherwise it's not going to go through the kidneys very well. So eGFR is reduced during glomerular disease processes, and you will see that in elevated plasma urea, creatinine concentration will be abnormal, and they also have reduced renal creatinine clearance. Acute glomerulonephritis, the highlighted areas are very important. Patients who had streptococcal pharyngitis are at high risk for this infection. patients with vasculitis or polyarteritis, bacterial endocarditis, autoimmune diseases. But the gold standard to diagnose this condition is kidney biopsy. Study that. RBC cast, relationship to hematuria, proteinuria, and hypertension, streptococcal pharyngitis with the group A beta hemolytic streptococci, and also patients who will have edema, hypertension, and impaired renal function in severe cases. These are all key points, okay? Study that. This is the pathophysiological mechanism of acute glomerulonephritis. Renal diseases causes inflammation of the glomerulus. Immune mechanism is damaged, damaging the glomerular capillary filtration membrane, including the endothelium, basement membrane, and epithelium, which is also called podocytes. And that causes sudden onset of all of those signs and symptoms listed here. Nephrotic syndrome, even though this is discussed again in the later on in other urinary disorders, but I wanted to bring this up because of the characteristic nature of the glomerular injury. Excretion of 3 gram or more protein is considered as massive proteinuria and hypoalbuminemia and peripheral edema. Those are the 3 characteristic signs of glomerular injury caused by nephrotic syndrome. So you have to know these levels and those 3 terms. And the causes, I've seen lupus is listed as causes of these, so I have highlighted those. A lot of times students pick all the kidney diseases and miss those systemic diseases like diabetes, amyloidosis, and lupus. So remember, there are secondary causes also that causes these 3 characteristic features like albumin, protein, and the edema findings. It also seen in patients with using certain drugs, infections, malignancies, and vascular disorders. UTI, you will see a question on this almost on all exams. In older adults, if you are taking geriatric exam, keep in mind the clinical manifestation in the elderly is confusion, delirium, weakness, and localized abdominal discomfort. I have highlighted it twice because I want you to know this. It's very difficult to diagnose in the elderly because of all these vague symptoms. In females, it's very common, but in male, if you suspect this, think prostatitis is the cause, okay? I've seen that term on exams also. Uncomplicated UTI in healthy female, usual symptom is urinary frequency. Gram-negative organism causes UTI in females a lot, and you will see on the UA leukoesterase or white cell cast, okay, high. Gram-negative. The most common cause of UTI with the uropathic strains are with E. coli. E. coli and secondary cause will be the one that we listed earlier, Klebsiella pneumoniae, Proteus mirabilis, E. fecalis, and Staph saprophyticus, okay? Risk factor is in women, usually menopausal women, those who are using contraceptives, patients with the low estrogen, have perivaginal colonization. That's what put them at risk. And also in male, like I said here, prostatitis is one of the cause, and the bacteria will be E. coli. Pyelonephritis, infection on both or upper urinary tract. These are the findings you will see: urinary obstruction and reflux of the urine from the bladder. That term is called a vesicoureteral reflux, most common underlying risk factor. And here again, those microorganisms are explained here. That causes pyelonephritis, E. coli, Proteus, and Pseudomonas, okay? And then hallmark sign is WBC cast. RBC cast was in glomerulonephritis. WBC cast is in pyelonephritis. Keep in mind, UTIs with the urease producing bacteria, they may have an infected stones, kidney stones. So this is very important. That put them at high risk for pyelonephritis, okay? They have already an experience with a kidney stone, they might have passed it, or they may still have it, and they have UTIs causing bacteria with urease producing bacteria. And what does it do? It split the urea into ammonia and make urine alkaline, and that increases the risk for stones. You have to know this. Painful bladder syndrome or interstitial cystitis. I've seen this in the clinical setting a lot, so I'm bringing this slide for your attention. Patients with radiation, chemical autoimmune or hypersensitivity reaction, they have this non-bacterial infectious cystitis. Usually it's a mycobacteria or chlamydia or fungus that is causing that. It can be non-infectious with all these other 4 components. The cause is normally, nobody knows exactly, but there is an autoimmune reaction that is responsible. There is mast cell activation, altered epithelial permeability, neuroinflammation, and sensory nervous sensitivity. White blood cast indicates pyelonephritis. I have highlighted that again. Some basics. This slide is very important because I have seen this. Some of the nurses or nurse practitioner students have no idea when we have a urinalysis or a 24-hour creatinine results come, they don't understand what that means. So I have created this slide for you to understand how the GFR and its relationship to serum creatinine. Serum creatinine level will change with increase or 50% of GFR loss over 24 hours. When we do the 24-hour creatinine test, urine creatinine, this is what we are looking for. In patients with acute kidney disease, it can become progressive and it can be reversible, okay? Make sure you know these. And the electrolyte imbalance that, as I mentioned in the earlier slides, hyperkalemia, metabolic acidosis, fluid retention, these will come on board. And then keep in mind, metabolic acidosis from hypercalcemia and bicarbonate deficiency. And when you prescribe ACE and ARBs for patients, make sure they do not have a history of bilateral renal artery stenosis because it put them at high risk for azotemia. Azotemia means abnormal levels of nitrogen in the blood. And that also has risk factors for AKI. Congestive heart failure patients, they have hypoperfusion of the kidneys because they have low cardiac output, and that put them as a high risk for acute prerenal kidney injury. Okay, acute prerenal is usually a congestive heart failure patient. They will also have a decrease in GFR. Once again, I'm bringing this exam taking skills. I want you to pay attention to all these key words that I have posted here. I'm sending you hugs of good luck, and as always, stay positive. Apply these clinical concepts that I have provided in these slides and apply these knowledge as you take any exams, and also you take care of your patients. God be with you. Thank you.